Hi, I'm Jack Cush with Room Now here at ACR 23 in San Diego. Today at the plenary session, this is Tuesday, there was a great presentation about methotrexate use in RA. This is abstract 1583 presented by Varun Dheer, where he presented the results of a study which looked at single-dose oral methotrexate versus split-dose oral methotrexate, both given weekly, in a large cohort of RA patients. The study was done at 6 centers in India. These are patients with about 2 years of disease activity and mean age at entry of around 41 years. They had to be seropositive, they had to have at least 4 tender and 2 swollen joints, and they were started on 15 milligrams, escalated to 20 in 2 weeks, and then 25 by week 4. And everyone was treated with 25 milligrams per week with supplemental folic acid. The primary endpoint of the study was unfortunately week 24. I'll say unfortunately because at week 16 they were still just on methotrexate, right? But at week 16, if they had a DAS that was greater than 3.2, the doctors could have added on leflunomide or sulfasalazine, and then the end of the study was 6 months or week 24, and that was the primary endpoint. Big mistake, as I'll show you in the results. So again, the study was sort of well recruited and well tolerated. The primary endpoint was at week 24, and the primary endpoint measure was a EULAR good response. Gotta say, I really still don't know what a EULAR good response is. And you know what? It wasn't different between split dose oral and single dose methotrexate, 25 milligrams a week. However, if you looked at week 16, when people were just on methotrexate only with no other add-ons, the differences were significant and highly significant. At week 16, split dose oral ACR 20 was 76% versus 52 with single dose. ACR 50, 55% versus 35%. ACR 70, 25 versus 14%. That's significant. Now, why am I making a big deal out of this? The problem is, once you use more than 15 milligrams of methotrexate, you know that oral absorption is highly variable and could go down by as much as 50%. And that's why when you get up to 15 milligrams a week, you should be going into split dose oral. And what does that mean? The people that got 25 milligrams all at once on Wednesday morning. The people who got the split dose oral got 15 in the morning and 10 milligrams in the evening. And what that does is it greatly increases the absorption and the blood levels of methotrexate, on par with that achieved by giving a parenteral dose of methotrexate. So that's why the study really helps inform practice, that once you're above 15 milligrams, you probably should go to split dose oral, and you'll see really optimal outcomes for your patients receiving methotrexate for RA. The question is, as you go to split dose oral and you deliver more drug to the patient, to the cell, do you not increase toxicity? And you should. However, in this study, they really didn't. They had actually more transaminitis, but these were not significant. They did have a little bit more in the way of nausea or GI symptoms, but it was not significant, right? Other things that were important in this study: the patients who got split dose oral had better improvement in their DAS28. They had less need for rescue DMARDs, the addition of leflunomide or sulfasalazine. That was like for 35% in people on split dose oral versus 55% in people that were on the single dose once a week. So this study, which was an open label blinded assessor study, 24 weeks, 253 patients, really does help inform practice, and I think you'll be hearing a lot about it. It comes from ACR 23. Tune in for more.